and we can have a lot many good evidence-based discussions. And there are very much what is the current, how to improve the confidence in managing the difficult cases. This is an idea. So, but today I'm really very happy that today we are having an esteemed speaker with us, Dr. Narendra Malhotra, a distinguished obstetrician, number one. Number two, a visionary leader. Number third is the decades of advancing laparoscopy, ultrasound, reproductive medicine, and you just call it anything which is benefiting to the countless couples. He is doing the work. Along with the leadership, which I am not going to detail about all his leadership, but his commitment for teaching, writing, mentoring, and has inspired the generation of gynecologists in India and beyond. And most of it, the most important point is all the compensate patient care-centered care and the practice, which is a role model for many of us, and a most grounded, most humble, and most simple person one can be. He is Dr. Narendra Malhotra. Anybody can read about him in a lot many things, but it's my idea of saying he's a great mentor and a great friend for many of us. So welcome, sir. Now you can share your presentations. Hello. Sir, you are unmute yourself.
A very good evening to all of you. It's indeed a pleasure to be here talking to all of you on a very, very important, you can see my slides?
Yes, sir.
On a very, very important topic called the probe and the scope. Now, this is very important in the life of a OBGYN, especially those who are dealing with reproductive issues and gynecology. And I bring you greetings from the city of Taj. Now, what our learning objectives today are going to be, we'll understand the range of the probes and the endoscopes in an infertility workup and reproductive work. So we have with us TVS, 3D TVS, saline infusion sonography, his HICO-C, HIFO-C, HSG, hysteroscopy, laparoscopy. So we'll try to review all the diagnostic accuracy of these and indications and limitations of each of these modalities. And we'll try to translate these findings to evidence-based management and decision. So you're going to see a lot of videos and how we can go ahead and do it ourselves. We all know what infertility is: failure to achieve a clinical pregnancy after 12 months of regular unprotected intercourse, according to the ASRM. And it is affecting about 10 to 15%, maybe more now. And the female factor in this is about 30 to 40%. 30 to 40% female, 30 to 40% male, and 10% the other factors. Early targeted imaging will improve your time to diagnosis and management planning. And that is what we call is use the probe to whenever you want to scope the patient. That should be your dictum and not take straight away for scopies. So our diagnostic pathway or the practical algorithm is going to be when you do an initial evaluation with history, menstrual pattern, semen analysis, ovulation assessment, AMH, AFC, per speculum examination. Remember, PS examination is very, very important, more important than PV, because per vaginum you are already putting the probe so you can get an idea, but a PS is very, very important to rule out the local cervicitis, cervical erosions and all that. Then we put in the probe, and in the imaging step 1 is transvaginal probe to evaluate from below the cervix, uterus, ovaries, tubes, adnexa. The further second is first one, once you've seen this, then step 2 is that you'll introduce a small Foley's catheter or a feeding tube in the cavity, and we'll do what we call as a saline infusion sonography for the cavity evaluation, or sonohysterography. You can use this, you can use a contrast which is known as HICO-C, and we can use some foam, HIFO-C. We can also use gel like xylocaine gels inside the uterus to get a better image. And this will give us tubal patency. HSG has a limited role now when you can do with the ultrasound, and we'll just show you that. And then, of course, if there is a positive finding, then only the scope comes into play. If there are no positive finding, everything appears normal, you need not do unnecessary laparoscopies and hysteroscopies. So our active management of infertility protocol is based on the probe and the scope is, if you have a young patient with the short duration of infertility, history, examination, semen analysis, routine blood test, TVS, sonosalpingography, sonohysterography. If pathology is detected, do a scope like fibroid, endometrioma, polyps, whatever is the pathology, tubal block. If the patient is over 30 years of age, but less than 35, and the infertility is more than 5 years or to 10 years. Usually at 30, women are getting married now these days, and it is not usually a long-standing infertility at 30 or 35. Here, straight away, the first thing which we have to, all the history will be remain the same, but extra importance has to be given to ovarian reserve. And ovarian reserve is very important. If the ovarian reserve is low and there is premature ovarian insufficiency, then 40, long-standing infertility, do her routine blood test, check her fitness for pregnancy. Ovarian reserve and endocrine testing is to be done, and early ART. If she's over 48, less than 50, which is the maximum age allowed by the government ART laws, then of course third-party reproduction options have to be discussed straight away on the first. No wasting time with doing unnecessary laparoscopies or unnecessary invasive testing in patients who are aged. Now, when we are going to do the probe, here is Dr. Mamta Diyal showing us how to do a transvaginal scan. And transvaginal scan, you can keep the thing inverted like this. You see that the uterus, fundus, posterior wall, anterior, and there is a lesion in the cavity. And that lesion in the cavity is very, very important because it is here where the implantation will occur. So we are going to assess the uterine morphology, fibroids, especially like this, which are submucous, ovarian reserve by doing an antral follicle count and looking at the adnexal pathology. Then the probe will also guide you to do the follicle monitoring and guide you for any intervention in IVF like follicle aspiration. And if you have color in 3D, it will tell you physiology, and 3D will give you anatomical structures very clear so that you can tell whether they are septum or not. So here we are going into the adnexa now after the uterus, and that is a dominant follicle you see on one of the sides. And when we turn the color, 75% of the follicular wall is colored. And this is day 12 or day 13 of the cycle. So we know that she has a very good follicle with good color supply. So this follicle will yield into a good M2 mature oocyte, and the pregnancy chances are very good. So ovulatory cycle is there. Now, abdominal ultrasound also has a role because patients may not allow, or they have vaginismus or any other vaginal severe infection. But abdominal ultrasound just gives you an overview. The exact things will be told only by TVS. And we add color Doppler like this. If the color Doppler does not pick up small vessels, we can add power Doppler and then go ahead and do saline sonography and all. So the vaginal probe ultrasound, the first step is by doing a 2D exam, a longitudinal image like this, fundus, anterior wall, posterior wall, endometrium, cervix. Endometrium is equidistant from all the walls, so no adenomyosis. One of the ovaries in the pouch of Douglas. When we put the 3D, we saw that both the cavities were diverging. So, or here the cavity was only slightly indented, what we used to call it as an arcuate, but this is normal. And here there is a small septum or what it is. But this is just by doing a 2D ultrasound. When we do it live, here we are doing live scanning from one end to the other. You see a very good 3-layer endometrium. You turn the probe to get a transverse view, and in the transverse view or in the longitudinal view, you find there is a space occupying lesion in the cavity here in between the cysting. So this is a polyp. To confirm it, we can put saline, and the saline will go all around and highlight this polyp very nicely, and also will you can do the color Doppler so that we get the blood flow to it. So sonohystrography or saline infusion sonography is done for indications like abnormal uterine bleeding, pelvic adhesions, pelvic pain, infertility, and this will evaluate the uterine cavity. So polyps, submucous fibroids, synechia, Asherman syndrome, congenital anomalies of the uterus, septum, biconvex uterus, all that can be seen by doing this. In addition, you can look at the Edidexa for doing. So what it does not need any preparation. The ultrasound machine is with you on your table, examination table. The patient you have examined by per speculum, just put her legs a little bit up, put in a Foley's catheter like we are doing here. So let's put in this, we're doing it for recording purpose. We did it in under anesthesia, but this is an OPD procedure and takes only 5 extra minutes or so. So we have 8 French Foleys. Now 8 French Foleys, see the connector is very difficult because with the normal syringe, you will not be able to push the, it goes in through, because it has got a stillet, it goes through very easily through any of the cervix. Very rigid cervix. Inflate the bulb with 1 to 2 ml only, not more, because uterine cavity is 3. Now see the other side, we have put in another Foley's. And then we look at the scan. We see that the Foley's bulb is in the cavity. The uterus is retroverted because it's away from here. That's a bladder which is filled up. And there is no free fluid, or there's a slight amount of free fluid, which we have noted before only. Then we will put the color on the whole screen and turn the probe to right and left. And when we push the saline, you see that the whole color bruit flows over the screen. That tells you that this tube is patent. Yes, you see. And these colors will be lighter in color. And when you stop, the flow stops and you see the normal vessels there. And then after that, we deflate the catheter. And once we'll deflate the catheter and then put saline, so the cavity will be highlighted. So in one single test, see the cavity is filling up and you see there is no polyp, no fibroid, no Asherman. Very nicely you can see. And when you look at the pouch of Douglas, the fluid which was there has increased. So it tells us tubes are patent. And you can also, only for the cavity, we can put in a small feeding tube where you're suspecting thick endometrium, polyp and all. So we just put a feeding tube, no inflating the balloon, and no balloon in there. And then look at the uterine cavity again, and you see that the tube is here. That plastic tube can be seen here. And there was a suspicious lesion here. So when we put the saline, we'll see whether that suspicious lesion. So it shows up as a polyp from the anterior wall. The pedicle is there and it is floating inside. So here the cavity, you see how good the cavity is. But this is only 2D ultrasound, not 3D. With 3D, it is much better. So doing a saline sonography, which is simple procedure like this, is an alternative to doing a diagnostic hysteroscopy. Again, we keep the diagnostic hysteroscopy for operative procedures. See, when we push saline, the bulb, and we inflate the bulb, we can do a tubal testing also. And if there was a polyp or an Asherman suspected, or there are repeated IVF implantation failures, then we go ahead and do the, see here, you see how nicely we can see the spill. And the spill is seen by various colors on the ovaries. Here we are entering into the cavity. We do without holding the cervix, vaginoscopy, and once you are in the cavity, that's what you were seeing by the ultrasound, the cavity here, and that is how you see it with the hysteroscope. So these are complementary, and this invasive, see, that is a cavity. That is a cavity. This is normal, nothing here. Same case, hysteroscopy later on, same case. So that is how we evaluate these things. See, thickened endometrium, I'm not sure whether there's a polyp or not. I put saline, both the endometrium layers go up and there is no polyp. And then I take a transcoronal section. I see that the coronal end are also seen and the cavity is good size. The Foley's is blocking the saline coming down and the cavity distends. Again, a polyp from the fundal end, suspicious, but on saline polyp, and we confirm whether they are vascular polyps or not. And then here we saw 3 or 4 of them. So definitely this will interfere. And then we went ahead and did a saline vaginoscopy first. So we go vaginoscopy and then enter with the pressure, and you see multiple polyps, the same multiple polyps hanging like that. And these have to be removed. So we go ahead and remove them by the scissors and remove them with it. There they are. So the big one, this one is floating here, and the other small ones are here. So exactly correlate. So your ultrasound, which is not difficult to do, you can do it yourself. Please do it yourself. And there is no need to do any or repeat any laparoscopy or hysteroscopy. It can be all under ultrasound guidance. Polyp seen, saline, polyp removed, confirmed. No hysteroscopy required to confirm this. Submucous fibroid, we need to know that they have to be classified according to the FICO. So here you see that this is a submucous, and that's our friend Dr. Osama Shoki, if you can recognize him, who's an he has been able to remove such type of fibroids, which are very risky to do. But if you have experience and you are very sure of your sonography, then you can go ahead and cut here. And when you cut here, the fibroid will pop out, and then you can, it's how to bring it down. Then in this case, we did it here. We put in a myoma screw by the side of the hysteroscope and then pulled this fibroid out. So that is historical, or that is difficult surgeries and heroic surgeries which should not be attempted by all of us. So but see, the screw is being tightened and we pull this fibroid out. Otherwise, we use the resectoscope. What about intrauterine adhesions? You see that there is a adhesion here. The saline is going both sides of the fluid, and there is an adhesion here. Very easy, very clear. We know this is adhesion. Sometimes it will break with the saline pressure. If it doesn't, go ahead and do a hysteroscopy. When there is endometrium is very thick and cystic, then again you can put in saline to rule out focal endometrial hyperplasia. Here was a generalized endometrial hyperplasia. And this will require biopsy. This will require a hysteroscopic guided biopsy or a curettage, and you take the tissue for pathology. So you've done. Now see, when you have 3D and you have the better machines, 3D polyp, fibroid like this is the polyp in all the 3, longitudinal, transverse, and coronal, which is not possible by 2D. And once we did this, we saw here, and then when we did the hysteroscopy, that is how this huge thing was protruding, this one. And then now this was a more than 2 centimeters. So here again, we have to be careful. It's very tempting to just go and cut the pedicle. So 2 centimeter submucous fibroid, if you cut the pedicle, how will you get it out? You'll have to dilate the cervix to 20. And if you dilate to 20 with a dilator, because 2 centimeters, then you will damage all the cervical tissue and it will be incompetent cervix. So you have to be patient and resect it out rather than removing it. So it is a non-invasive method using saline. Now, if you want to know the site of the block and want to know everything, then we do with the contrast. It is the same way with the contrast. Speculum, introduction of the cannula, and injection. See, this is saline, which is showing, and this is contrast, which is showing. Contrast with 3D. How nicely you can see the spill on the both sides. So the contrast material will appear white and not black with the saline. If there was a block here, it will not go ahead of it, and that will be picked out. So people who say that you cannot pick up the site of the block, yes, we can if we do use the HICO-C, and HICO-C is with the same way, same Foley's, same this thing, but the contrast is expensive. That is how it is available in India, and one bottle can be used for 2 patients. I think it is 4,000 or 5,000 rupees. But you see how the cornwall end, how the whole tube is outlined, how the block is seen here after the cornwall, how this tube is patent and it goes all over. So that is how. See here, in live, you can see here the contrast is going in the tube. In black and white, we have highlighted it and then spill over here. So the whole tube can be outlined and tubal blocks can be picked up. This requires a little bit of skill and a little bit of learning curve to do this. But you can get with 3D pictures like this of the whole tube. Now, this is as good as a laparoscopy. Yeah, in laparoscopy also you see something like this. So it is probably non-invasive and as good as laparoscopy. Tubal patency by contrast can be done again in the same way. You use the contrast, you can use foam which is available, you can use even gel which is xylocaine, sterile xylocaine gel, inject that and that will give you. Now if there is hydrosalpinx, it'll bloat up and the spill will be only in the hydrosalpinx. Then we take a 3D picture of that, and with the 3D picture you can see that the hydrosalpinx is very, very clearly seen, and this again has to be removed before you go in for this. So this is sono AVC of the hydrosalpinx. So you can take the volume that all these machines will do it automatically for you. Just have to aim the probe there and press the button. Now, tubal blocks can also be managed by the scope at the same sitting, or we have also done it in the workshops by ultrasound. Now, if you have a Cornwall block, then we can use the Janssen-Anderson cannula, cannulate the cornua and look for the spill by ultrasound color Doppler or by laparoscope. So that is where both of them can be added or used together. So that is where it is. So use the probe for diagnosis at first. First step is vaginal ultrasound. Diagnose the uterus, endometrium, ovary, peritoneal, bladder. Second step is to pushing in saline, confirming the uterine pathology, polyp, submucous fibroids, adhesion or hyperplasia. Third is sonohysterography, where you do the tubal patency and look for the patent tubes or block tubes, and ovarian adhesions. When you do the push and pull sign and the ovary slides over the uterus, that means there is no pelvic endometriosis. So we can even tell that. The Hycosi is expensive. Saline is good enough, or you can take betadine, agitate it with some saline, or you can do any hydrotubation fluid, saline with antibiotic with hydrocortisone with Hyalase, and that will take care of the PID also. And if the infection has blocking the tube, some membranous, that antibiotic will take care of that also and work as therapeutic. And of course, if you have 3D, 4D, then the pictures which we showed you of 3D, 4D will be something like this. So which will be much, much better and clear. Now, what probes do we use? We have a 2D probe, which is like this, which will give you one direction. The sound wave goes in one direction. And so you have touched the cervix, you see longitudinal. You rotate the probe, or to the right, you see a cross section. And you go to the right, left, you see the left adnexa. You go to the right, you see the right adnexa. So push, pull, rotate, and pan to get the whole pelvis. That you have to do manually. If you have a 3D probe like this, the 3D probe, you have to just keep it in the center. And the 3D will sweep the whole pelvis from one. The 3D wave sweeps like this, sweeps like that. X, Y, and Z axis. And makes an image for you. And that image is like this, where you see it has made an image and it's showing that there is a polyp there. Now we can use fancy colors to know exactly where the polyp is and how it is interfering. And then we can turn the color and know that how much. There are two vessels, so you can guide. If you're doing hysteroscopy, you are now aware that this might bleed because there was a big vessel supplying it. So you're going to use the resectoscope bipolar. If it bleeds, you will cauterize it, or post-operative, you'll put in a Foley's for a hemostatic, inflate the Foley's for 24 to 48 hours for hemostatic effect. Now let us go organ-wise. After the knowing, quickly we'll see what can we do for ovaries. We come from up down. We know we should be well aware of the anatomy and well aware of the physiology and the vasculature and the vascular supply. Then only you can make sense with ultrasound. So we know that the uterus and the pelvis, bladder is anterior, rectum is posterior, both sides there is the round ligament, there's the tube, there is ovarian ligament, there's ovary, and there's infundibulopelvic ligament. So all this can be seen and then the uterine arteries come from both sides, divide into anterior, posterior. The ovarian artery comes from the aorta directly and the tubal artery, and there is an anastomosis there. So once we're going to do the vessel study, we will know whether this vessel is dilated or constricted. The amount of blood it is allowing to go in systole and in the diastole. Now, when a heart beats in systole, blood will rush forward, and a uterine artery and ovarian artery, being muscular, will open up and let blood go, and you get a systolic peak. When the heart goes in diastole, this muscular artery comes back, and when it comes back, it will still push the blood forward to the organ. All muscular arteries will do that. So you have a systole and you have a diastolic flow. This diastolic flow is 1/3 of the systolic flow in normal muscular artery, whether it is renal, whether it's celiac, whether it's aorta, whether it's brain, wherever it is. If the diastolic flow is not 30% of the systolic and it is less, that means that artery is constricted, and it is constricted because of atherosclerosis or because of adhesion or something pressing. When the diastolic flow is more than 30%, that means that artery is dilated and letting more blood go in diastole, which can be physiological in pregnancy, at time of ovulation, at time of implantation, in benign tumors. When it is dilated too much and letting 60% of the peak go into the diastole, then it is malignancy. So color Doppler is no rocket science. Most of us read the values and get very confused with the values. What is PI? What is PSV? What? Just I will request all of you to look at the waves. You look at the waves, you can diagnose what kind of lesion or how much blood is. 70% systole, 30% diastole, normal. Less than 30% diastolic wave, abnormal, atherosclerotic, less blood going. More dilated, up to 40%, benign tumor, up to 60%, malignancy. That's it. So it makes it simple. Then count. Now, antral follicle count is done by measuring 2 to 10 millimeters follicles, which may be arranged peripherally or rapidly wherever. Here, see, we count here 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Now, the revised criteria by Rotterdam is 20 in each ovaries, then only you say PMOS with a lot of stroma and the ovarian volume more than 10. But here the follicle, now you will not label this as POMS. You will label this as polycystic ovarian morphology. That means the ovary is showing a morphology which is similar to PCO, but it does not come into that. This is the commonest mistake which radiologists are doing. They will label anything over 5-6 follicles, label it at PCO. So which is wrong, and that is why the name has been changed from polycystic to polyendocrinic metabolic ovarian syndrome, because it's more of metabolic and endocrine rather than the number of cysts which you see. So that is very important. Now, where do we see the ovaries? We see the ovaries in the ovarian fossa, and that's I'm doing the push and pull, and you can see the push and pull here and here. So the uterus and the ovary, if they move together, that means they are adherent. So here, in this case, there is this uterine wall, peritoneum is stuck to the ovary. So this is endometriosis or PID. And if the ovary slides over the uterus, then there are no adhesions, and you see that it is sliding smoothly over the pouch of Douglas, and the uterus is not adherent in the pouch. So you can make out adhesions which previously we thought will not be able to tell. Then for a reproductive medicine specialist or you have to assess the ovary, because if she has to go for IVF, in the dummy cycle, in the registration, during stimulation, want to know whether the ovary is accessible to the needle transvaginally or not. Some ovaries may be stuck at the brim, pelvic brim, or even higher up. They cannot be assessed transvaginally because the bowel and all will be coming in between. So for those, we'll have to do a abdominal oocyte retrieval or a laparoscopic one. Now, here, then of course, I showed you first that the vasculature has to be studied. So dominant follicle, vasculature, and what is there? And then in all the machines now we have what we call as the sono CT. So it gives slices of image, just like an MRI or a CT. And that will tell you to assess the ovary in all the planes very easily, rather than a 3D. Remember, follicle monitoring has to begin on day 2 during menstrual cycle transvaginally, which again the radiologist will not do. Menses ho raha hai, kaise kare, ye kare. They have to be assessed. For there, you have to assess whether there is an endometrioma, whether there is a persistent follicular cyst, whether there is PMOS, whether there is proper endometrial shedding or not. Then only your stimulation can be planned. So better to do yourself rather than ask. Day 6, under the influence of gonadotrophins, these follicles will grow. Whether natural cycle, if you're giving clomiphene, letrozole, HMG, then there'll be many follicles. Now, this is not polycystic, this is many follicles. So ideal is 6 follicles, 10 to 12 millimeters on day 6. So we're sure that our stimulation. Day 9, all these follicles will grow up and each follicle will develop its own blood supply. Now, this is appearing orange, not red and blue, because we're using power Doppler here. And at this time, you look at the endometrium to see correlation. So endometrium should also be 3-layered and good. So ovarian endometrial correlation has to be seen.
Absolutely beautiful endometrium.
So here, that's the ovarian follicle and that's the good endometrium. And once the follicular wall infolds, that means it's about to rupture. And sometimes you can see cumulus. Most of the times you can see cumulus also. So you will time the HCG when you see the cumulus. In a stimulated cycle at 16 to 17, in a down-regulated cycle at 18. If you give HCG too early or too late, then there will be the commonest cause of luteinized unruptured follicle syndrome. So that has to be done. Now, if you have an ovarian pathology on day 2, this is what we do. So like most of them will write cyst 4 centimeters, 3 centimeters. And if they land up with a laparoscopically surgeon, laparoscopy. So cyst of this size, if you go to do laparoscopy, it's going to recur. And so we put in a needle, drain the cyst. We have escarole available. This is how we foam the escarole. And we will inject it into the cyst after draining it. So cause artificial inflammation of the cyst wall. And the cyst wall will stick to each other. And you can go ahead with your stimulation protocol. 80% of these simple, small cysts, less than 5 centimeters, will get cured. We've even tried it for endometriomas because repeated surgeries in endometrioma will damage the ovary completely and permanently. So that's the ampule of escarole, 100 rupees only. You take it in this thing, you put a 3-way on it, you foam it, and then inject. Then if there are other lesions, we have to be classified according to the IOTA classification because we don't want to miss any cyst which may be malignant. So theca hemorrhagic cysts, benign cystic teratomas, endometriomas, cyst adenomas, malignant cyst, by the aorta and the Edinex app, which is on your phone, you can do that to all the cysts and of course do a Roma biochemical markers so that you have not missed a malignancy even in a simple looking cyst. That is very, very important. Endometriomas, again, surgery is required where they are very big, where they're causing distortion and where the stimulation ovary is not available, normal ovarian tissue. So big endometriomas, we'll drain them, de-roof them, do a cystectomy, use less amount of cautery so that we don't burn the. Now in unmarried girls, if she comes with a 5 centimeter or 6 centimeter endometrium and you see normal ovary all around, then it is advisable to drain this by ultrasound guidance and stimulate her and do egg freezing in 2 or 3 cycles. So later on, she's just 16, 17. There was a patient just now here. So 2 times we have drained her and stimulated and we have stored about 20 follicles. Now whenever she wants to get married, now she will undergo the surgery because surgery will reduce the AMH and reduce the ovarian reserve. So the surgery also has to be done neatly. Now endometriomas, whoever does it, any neatly amount, it is going to recur. So draining and oocyte preservation should be counseled to these girls when you see endometriomas like this. What about hydrosalpinx? Again, we do laparoscopy for clipping the hydrosalpinx. Again, an invasive. We can again go ahead by ultrasound, drain this, inject some antibiotic in it and inject sclerosing agent. And there is a good amount of papers showing that ultrasound guided drainage and sclerosing agent works as good as laparoscopy. So you've saved them. There may be some endometriomas which appear differently. like septate, like solid regions, like reticulate walls. Now, there are various levels and they will be classified under the IOTA screening to know what it is benign or not. Patients who are going for IVF, you need to have a biopsy guide. You need to have a 30 centimeter needle. You need to have the ovary right next to the vaginal wall. So you puncture the ovary, like here we are doing it. Now this is, sorry, this video is not working. This is where we went for training to Norway, and in that hospital, no anesthesia was given. The woman is watching the oocyte retrieval and collection of the fluid. This is not possible in India. We give short GA, or you can give a cervical block with the special needle. All embryo transfers are now done under ultrasound guidance. So that is where again your ultrasound comes into play, because the maximum implantation site is here, which is you draw 2 lines from the cornua into the center is here, and that only ultrasound can tell you. And ultrasound, 3D ultrasound can point out there. And during that also we are leaving the embryos at that site. Ultrasound guided IUI, well, we don't recommend this, but there are some papers saying it might have a better result, because sometimes IUI you can put the semen here also, but IUI will work wherever you put the semen if there is no other problem. If there is high order multiple pregnancy, then we'll use that same ultrasound for multifetal reduction. Again, a controversial thing is what gestation you should be doing it. If you do it early at 8 weeks, the dead weight of the dead fetus is less. If we do it early, we miss the nuchal translucency. So we can nuchal translucency. So you do it at 11 weeks. Your choice. After seeing the uterus and all, we have to study the endometrium. Longitudinal cross section 3D. Limitations with the 2D ultrasound is you don't see the coronal plane, and you need to know the endometrial myometrial junction. This should be very healthy. So early breakage of the endometrial myometrial junction, small buds of endometrium, lines, shadowing, islands, classical case of Amos or classical case of adenomyosis. In the uterus, uterine anomalies and receptivity. Uterine artery, as I told you, should let blood go more at the time. Uterine thickness should be more than 6 or 7. Uterine pattern should be 3-layer, good 3-layer or 5-layer. Uterine receptivity, blood flow should be more in the uterine artery and the spiral artery. And the spiral artery blood flow is seen like this, and you can do vascularization studies like this. So day 6, day 9, day of embryo transfer or IUI. That is how the spiral, very simple, 1 extra minute on your scan. Where we need volume in adenomyosis. If the volume of the uterine cavity is too much, then pregnancies will not occur. So you need volume there. Mullerian dysgenesis, anagenesis, and septate cross-section, again, ultrasound today is the gold standard rather than doing HSG or laparoscopy or man. So these are 2 magic sticks in your hands. One is the probe and one is the scope. And once you do the diagnosis with the probe, you go ahead and do the treatment with it. And we diagnose the uterine anomalies now as UCV or VCU, the uterine, especially normal uterus U0, U1, U2, U3, Escherich's classification, not the American classification. So you have to see that the fundus is true. Both convex, it's normal. Upper convex, inside concave, septate. Grade the septum according to the Escherichs. Normal, U0, bicornuate, septate, subseptate, and then or T-shaped. And then you can plan whether if you believe in doing a lateral metroplasty, fundal metroplasty to increase, then you go ahead and use the scope. Septum, this was right from the vagina, and from the vagina only we cut it with the bipolar. So vagina, we filled it with fluid and start cutting from there. So no stitches required. So the practical approach is you have to look at the serosal surface and you have to look at the endometrial surface for diagnosing normal, arcuate, and septate. The fundus has to be seen, and there has to be something like this. So serosal surface indented more than 1 centimeters, septum, or bicornuate or didelphus or normal. That's how we do. And with ultrasound, we can pick them up now 100% specificity and 98% septic. And then you approach use the hysteroscope approach or a laparoscopic approach or whatever it is. If it is biconvex, then sometimes you need to do laparoscopically join the cavities. That will depend on the surgeon on how big it. Usually they are done with it. Follicle, we've already told you about the follicle monitoring, how it is done. But in COVID times, we had the patient could not come, or clinics which are very busy. Now we have portable transvaginal ultrasound. Unfortunately, this is not allowed in India. This woman takes it for pregnancy. She is just putting it on her abdomen and consulting the doctor at the same time. So that monitoring. Similarly, the transvaginal probe is given to the lady. She inserts it into the vagina, a self-scanning device, we call it. And on your mobile app, you can guide her, put it on the right, put it on the left, get the picture and plan the further treatment cycle. So these are what the advances. So this is app guided, what we call as 5-step self-scan. Self or a clinician guided scan. So, ladies and gentlemen, to image with the probe and to translate the management by the scope, especially in polyps, fibroids, hydrosalpinx, tubal occlusions, endometriosis and all, and schedule this. There are some limitations like of all the tests, but this is something which is the future direction is everyone will have this in their clinic, and simple probes will fit into your finger, and you can, at the time of PV, you can do imaging. So what we call as marrying palpation with imaging. So the take home message is TVS, 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 please learn it yourself, do it yourself for a diagnosis, and don't go ahead and do laparoscopies for all infertility patients, because 80% of them will come out to be normal if you do it all. Only do it where the TVS says there is an abnormality. We have put all this in our step-by-step series, which are also available in foreign languages. Anyone can get them from JP Publishers and read them for it. Also, there is a suggested reading by ASRM Practice Committee Guidelines, the ASHRAE Guidelines, and the review transvaginal sonography infertility reviews of 24-25 to get exact pictures. Thank you very much for inviting me here, Dr. Kawita, and letting me speak on something which I believe is the thing for evaluating the reproductive tract of the woman. Thank you.